Hemolysis is defined as decreased red cell survival caused by an inherent abnormality of the cell and/or by extrinsic factors. When hemolysis occurs at a rate that cannot be compensated by increased red cell production, then the patient presents with hemolytic anemia. The first branch point in the classification scheme is based on whether or not the hemolytic anemia is mediated by immune mechanisms or non-immune mechanisms. Immune mechanisms, in turn, are mediated by the binding of antibodies to the red cell membrane, leading either to lysis of the red cell in the circulation, so-called intravascular hemolysis, or by Fc-mediated uptake of the red cell by macrophages in the spleen and the liver, that is, extravascular hemolysis. Immune-mediated destruction of red cells may be due to autoantibodies that target red cell antigens on the patient's own erythrocytes, or to alloantibodies that can develop after sensitization and exposure to incompatible donor red cells. Autoimmune hemolytic anemia is classified into three major types based on the optimal temperature at which the autoantibodies bind to the patient's red cells in vivo. Warm antibody autoimmune hemolytic anemia is usually mediated by IgG, less often by IgA or IgM, with optimal antibody binding occurring at 37 degrees Celsius. In cold autoimmune hemolytic anemia, hemolysis occurs due to autoantibodies that target red cell antigens with optimal activity between 0 and 4 degrees Celsius, typically antibodies of the IgM class. Mixed autoimmune hemolytic anemia involves hemolysis due to the presence of both warm and cold reactive autoantibodies. Alloimmune hemolytic anemia may occur as a potentially fatal acute transfusion reaction, usually resulting from transfusion of ABO-incompatible red cells, or as a delayed reaction, typically within 24 hours of transfusion, occurring as the result of an amnestic immune response in a previously allo-immunized patient. As a general rule, immune-mediated hemolysis, whether auto or alloimmune, is detected using the direct antiglobulin test, DAT, otherwise known as the Coombs test, which will be positive for IgG and/or complement. DAT-negative hemolytic anemia points to a non-immune mechanism, which can be divided into intracorpuscular and extracorpuscular causes. With intracorpuscular etiologies, the defect lies within the red blood cell, at the level of hemoglobin, the cytoskeletal membrane, or intracellular enzymes. Hemoglobinopathies consist of sickle cell disease and the thalassemias. Sickle cell disease, in turn, includes homozygous sickle cell anemia, hemoglobin SS, compound heterozygous hemoglobin SC disease, hemoglobin SC, and compound heterozygous sickle beta thalassemia. Thalassemia may be caused by mutations in the alpha or beta gene locus, leading to alpha and beta thalassemia, respectively. In terms of red cell membrane abnormalities, the two most common causes of inherited hemolytic anemia are hereditary spherocytosis and hereditary elliptocytosis. Hereditary red cell enzymopathies include G6PD deficiency, which involves the pentose phosphate pathway, and the much less common pyruvate kinase deficiency caused by a defect in the glycolytic pathway. Every condition I have mentioned so far in the intracorpuscular bucket is congenital or hereditary in origin. We can add to this list a single acquired condition, PNH, that is paroxysmal nocturnal hemoglobinuria, as a cause of non-immune intracorpuscular hemolysis. PNH results from a non-malignant somatic mutation in the X-linked PIG-A gene, which leads to deficiency of CD55 and CD59 on the red cell surface, and activation of the alternative complement pathway, ultimately leading to lysis of the red blood cell. Now we come to the extracorpuscular causes of non-immune hemolysis. Here the defect lies outside the red cell, in the cell's extracellular environment, the erythrocyte being simply an innocent bystander. There are various causes which may be organized into subgroups. One such group includes the thrombotic microangiopathies, or TMAs, and microangiopathic hemolytic anemia, the so-called MAHA. TMAs are a group of rare disorders characterized by thrombocytopenia, MAHA, and microvascular thrombus formation resulting in end organ damage. They include but are not limited to TTP, HUS, and DIC. MAHA is a descriptive term for non-immune hemolysis resulting from intravascular red blood cell fragmentation that produces schistocytes on the peripheral blood smear. Abnormalities in the microvasculature, including small arterioles and capillaries, are frequently involved. However, intravascular devices such as prosthetic heart valves or assist devices, though not exactly microvascular in nature, may also cause a MAHA-like picture. Rare cases of significant repetitive impact, such as occurs with marathon running or hand drumming, may also cause MAHA. Certain types of infection may lead to hemolysis, most notably babesiosis, malaria, and Clostridium perfringens. Liver disease is not uncommonly associated with hemolytic anemia. For example, in spur cell anemia, associated with an abundance of acanthocytes on the peripheral smear, Zeev syndrome, seen in those with alcohol abuse, and Wilson's disease, which is associated with high copper levels in the blood, which are toxic to red blood cells. Finally, there are rare causes of non-immune extracorpuscular hemolytic anemia, including thermal damage and envenomation. Finally, when considering a patient whose hemolytic markers are positive, it is important to consider three conditions that mimic classic hemolysis. The first is vitamin B12 deficiency, where ineffective erythropoiesis in the bone marrow leads to early destruction of erythroid precursors, resulting in elevated serum LDH and bilirubin levels and low serum levels of haptoglobin. A similar profile may be observed in the setting of resorbing hematoma as well as in patients with HLH.